I'm happy to have the honor again this year of introducing our speaker for the 10th annual Dr. Pinkstaff Lectureship. I was talking to Dr. Hassick and telling her about Dr. Pinkstaff and just the positive effects he had on so many people. He had a contagious smile and just happy attitude, and always had something positive to say to every person he worked with, family he interacted with, and I feel very lucky that I was able to work with him. He was a great teacher, mentor, friend. Dr. Pinkstaff had a passion for all things pediatrics, but especially for kids with special health care needs, including autism, and I think he would be very excited about our topic today. To introduce our speaker, it's Dr. Sandra Hasnick. She has devoted her professional career to caring and advocating for children with obesity and is the current medical director of the AAP Institute for Healthy Childhood Weight, which is focused on translating research into practice for pediatric healthcare providers and families and children. Dr. Hasnick has testified before Congress on childhood obesity, food insecurity, and hunger, focusing on supporting the foundation of child health. Dr. Hasnick is the chair of the Institute for Medicaid Innovation, Child and Adolescent Subcommittee, and a member of the National Advisory Board. She is a past board member and past president of the American Academy of Pediatrics. Dr. Hasnick began the weight management clinic at Nemours A.I. DuPont Children's Hospital in 1988. She has collaborated in basic research efforts to identify pathophysiologic mechanisms of obesity, centering on the role of leptin, and has lectured widely in the field of pediatric obesity. In addition, she has authored A Parent's Guide to Childhood Obesity, Pediatric Obesity Prevention, Intervention, and Treatment Strategies for Primary Care, and a clinical guide to pediatric weight management. Dr. Hasnick has served on the Institute of Medicine Committee on Accelerating Progress in Obesity Prevention and was an author on the expert recommendations for obesity. Dr. Hasnick also holds a Master of Science in Pastoral Care and Counseling. We feel very honored today to have her speak at our Pinkstaff Lectureship, and we look forward to hearing from you.
Thank you very much, Melissa, and we will get started. I'm very happy to be here with everyone today. I wish I could see y'all. Today's lecture is Obesity Treatment for Children with Autism and on the Autism Spectrum Disorders, and we're going to spend a little time this morning looking at the etiology and pathophysiology of obesity, reminding ourselves of the risk factors, and then drill down understanding obesity treatment in the context of children with autism. So when we look at the definition of obesity, we see that it's a condition characterized by excessive accumulation and storage of fat in the body. And we've been stuck on this definition in a manner of speaking. And when we think about it, it implies obesity is just a matter of quantity. It focuses on an outdated now concept that adipose tissue is mostly an inert storage deposit for fat, and it keeps us from appreciating the dynamic, complex, multi-system disease of obesity. So when we look at our updated definitions, one from the Obesity Medicine Association, obesity is a chronic, relapsing, multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. So clearly we've moved into the arena where we're defining obesity as a chronic disease. And if we look at our own definition, how it pertains to children, obesity is a chronic disease that results in altered anatomy, physiology, and metabolism, all of which adversely affect the physical and mental health trajectories of our children and adolescents. So just a reminder that this is a disease of dysfunctional adipose tissue. It has anatomic significance with excess fat, surely, and ectopic adipose tissue contributing to organ dysfunction, such as sleep apnea and liver disease. It affects us physiologically. It's a pro-inflammatory disorder, and promotes organ dysfunction, and it has neurobiological effects. It leads to inflammation within the appetite control centers in the hypothalamus, decreasing our responsiveness to hunger and satiety signals from other parts of the body. So just as a reminder, we're dealing here with a complex chronic disease. And we've all seen these comorbidities in our children with obesity. We won't spend a lot of time. Just to remind you that obesity affects it's a multi-system effect and affects almost every organ system that children have. It's also highly prevalent. So we see that the prevalence in different age groups, and obesity surely is involved in now 18% of our children overall. And it increases with age. So even our youngest children have an almost 10% prevalence of obesity. This escalates over the years, and you can see the transition between adolescence and young adulthood. Our young adults are significantly affected. You all know this. And so we have an opportunity as pediatricians to get in early and try to do some work on embedding these healthy lifestyles in our patients' lives. You can see that last bar is severe obesity. We have about 8% of children who are severely affected by this disease. And it varies by not only age, but by race and ethnicity. And you see across the age spectrum that Mexican American children and non-Hispanic Black children are more and more affected as time goes on. It also compromises our foundations of health. And so if you look at what are the foundational elements for health in children, sound and appropriate nutrition is one, stable, responsive environment of relationships, nurturing relationships, protective relationships is another, and safe, supportive, physical, chemical, and built environment is another. And this comes from the Center on the Developing Child at Harvard. And so nutrition is a cornerstone of building the foundations of health for our children. And this foundational elements of health are built all across the socioecological spectrum. Child's individual life and characteristics, how the family is, the context of that family, the lifestyle, the family system, and in the community. So we're working with a chronic disease that has a longitudinal effect on children, that has risk factors that are more or less spread throughout the socioecological spectrum. And I think it's important to realize that, you know, we are very well understand the population health implications of obesity, but we see one child at a time. And each child moves through their own unique microenvironments. So they have a series of physical microenvironments, what's their family, their daycare, their school, their communities, and actually a series of behavioral microenvironments. They move through stressful events, death of a parent, illness, school change, abuse, teasing and bullying, COVID. They have changing child-parent dynamics around food, eating activity, and weight. There's an interaction here between the resiliency and the response. They have a series of environments about the adults around them who model eating and activity behaviors for them. And the media, of course, is an ever-changing environment. But these environments are both broad throughout the population and unique to each child. We know that obesity treatment takes a lot of systems to be involved. Pediatric primary care is the linchpin here, but we have our subspecialists, the resources in our health systems, payment, policy, food supply, safe and available activity, community programs and resources all need to be in play to effectively treat childhood obesity. So in a survey when parents were asked, where do you most expect to find resources for learning about childhood obesity? Guess what? We were it. The vast majority of parents identified doctors as the place where they wanted to come to find resources and information about obesity, followed by media, schools, community centers, but tag, we're it. So what do we do? And we're just very briefly going to look at what the expert recommendations for childhood obesity are. Surely we all are assessing BMI, nutrition, activity, and readiness to change. We want to use evidence-based information to help our patients in both obesity prevention and treatment, and this is a stepwise incremental approach. We want to avail ourselves of not only what happens in primary care, but how our subspecialists can help us and how our multidisciplinary team can help us. And surely this is family-centered because nothing happens with that child without the family getting on board. And I just wanted to show you that we do have consistent evidence where multiple studies have shown an association between recommended behavior and obesity risk or energy balance. And you're all very familiar with this. Limit consumption of sugar-sweetened beverages, limit screen time, no TV in the bedroom, breakfast eating, limit eating out, encourage family meals, limit portions. Sleep has been added since the recommendation publication. And there are many more, but these form the backbone of the expert recommendations. We also have a list of things that are suggestive and possibly helpful. Calcium, fiber, balanced macronutrients, moderate to vigorous activity, and limit consumption of energy-dense foods. And you'll know I started breastfeeding there because although there is plus minus evidence on breastfeeding, the tilt of the evidence is that breastfeeding is a protective factor, one of them in obesity management. We now are drilling down to look at our youngest children. We know that the rate of weight gain during infancy is highly predictive of later obesity, that infant feeding, appropriate bottle feeding, responsive feeding practices are very important to setting those early patterns, those early health style, the nutritional patterns, establishing routines, activity early on, sleep, and then you see the elements that affect older kids. So now we're starting to really think about how do we prevent obesity right from birth and even attend to the healthy pregnancy of the mom to do that. Now we do have some guidelines, and these guidelines are available, algorithms for management of children with obesity. And we want to think about what we're doing here when we have a child with obesity come to see us. We're assessing growth, doing what we normally do, history of present illness. Here we're honing down on nutrition and physical activity, and we're looking at the trajectory of weight gain. When did that weight gain start? And does that inflection point in the growth chart tell us anything about what changed in that child's microenvironment? Was there a separation? Was there a school change? Was something happening that we can understand to help that child? We want to do a complete review of systems, including obesity-related comorbidities, and assess psychosocial family system and medical risk. When we do that, we are armed here with information where we can then address the family's chief concern, so we can orient our discussions around goal setting and move into the actual obesity treatment. We want to make sure we prioritize individualized family-led behavioral counseling here. It's a behavioral approach where we have our evidence in front of us, we have the status and assessment of the child, we have the risk, and now we need to understand where the family is and where they're motivated to go, and help them put their feet on that road to getting a healthy lifestyle. We want to make sure that we set goals and assess goals. So if you set a goal with the family, make sure when that family comes back, you remember what goals they were working on, and you ask them about the goals. And there's nothing more discouraging than to come back and find that the provider doesn't remember what goals that you set the last time that you were working hard on. Obesity is a chronic longitudinal disease, and it needs follow-up. So every patient you see, you need a plan for follow-up. If they don't come back, they're likely not to get better. And you want to think about what your desired outcomes are. At first, it may not always be weight. It often isn't. It's behavior change and progress on the goals. Again, when we do our follow-up visits, we want to go through reviewing our health status, reviewing the goals. We want to affirm the strength of the patient. We want to, if the patient has made any progress, coming back is progress, working on goals, understanding barriers, that's all progress. And we want to help the patient affirm that. And then we want to encourage always the patient and family on the journey because we're partners with them. Does this work? the U.S. Preventive Services Task Force gave obesity treatment a grade B and recommended that all children over 6 be referred for who had obesity be referred to treatment. So yes, we have evidence, and we know that parents are crucial here. This is a study by Len Epstein where he treated the child alone or the child and family, and we all know this inherently as pediatricians. We are essentially treating the family here. A core skill of obesity treatment is motivational interviewing. And this is a way of discussing change that allows the family to be involved and understand what motivates them, and have the families basically participating in goal setting and follow-up. And doing motivational interviewing itself helps us be aware of where the family's coming from, what's important to them, what are the significance of meals and eating, because we're actually having a dialogue with the family about what's going on in the family, what they're motivated to change, maybe how to help them get motivated to change, and really understanding for them as unique families and individuals what will work. We talked about the team before, and there are many people who can help you take care of your children with obesity, and they can fulfill, different people can fill different roles. So you might want to have you might have access to a health coach or an educator or a dietitian who can help with the behavior change. You might need to refer the child to a psychologist, sometimes even before you can really get started with obesity treatment. As you're getting started, you might want that referral. You have your physicians, nurse practitioners, physician's assistants to work on the medical management, and certainly your subspecialists and are well in play, especially with the obesity comorbidities, and often you might have somebody, a case manager in your office, to help you with coordination. I wanted to make a specific point about stigma and weight bias. This is unfortunate for us because obesity is a disease that has a lot of stigma and bias attached. And so the AAP put out a policy in 2017 about how we should handle this. And we won't go over this in detail. I refer you to this policy, but we need to be careful about how we role model our behavior, what language and word choices we use, and be sensitive that weight, body mass index is much less stigmatizing than obesity or fat, and remind ourselves to use people first language, such as a child with obesity, rather than obese child. Obesity is a medical diagnosis and should be documented, and sometimes you have to explain to your patients why you're putting that diagnosis on the chart. And part of eliminating bias is to use patient-centered, empathic behavior change approaches and collaboratively engage the patient. So, and that's a way of affirming that patient as a person. We want to create safe, warm, and inviting clinical environments that are non-stigmatizing. We want to assess our patients not only for the medical risk, but the psychosocial risk, especially because many to most of them have been subject to bullying and teasing, and we want to advocate against weight stigma. I'll refer you here to an app. You can find this on your phone or on any app store. It's free. We developed this app to help people get acquainted with motivational interviewing, and there's 3 scenarios there, and you actually can test your motivational interviewing skills on this app. It's a lot of fun. A lot of residents, nurses, physicians have used this to dip their feet in that water. So that's a quick overview of where we are with obesity. Now we're going to specifically think about our children with autism spectrum disorder. So we know that there's an increased obesity prevalence in this population of children. The same factors are operative here: non-Caucasian race, increasing age are risk factors. Girls often are higher in obesity rates, and this was a global study, so the United States, unfortunately, was higher than many other countries. Obesity starts young, as you saw on my graph, and it starts young in children with autism at higher rates than children without autism, and it extends into adulthood. And the extension into adulthood, obesity not only causes chronic disease in childhood, but that extension into adulthood, it really is a driver for adult chronic disease. So this adds a burden to your patients with autism who are already struggling with not only autism, but have higher rates of chronic disease. If they have obesity, this just adds an increasing burden to them. And here you see a graph with obesity and comorbidities in children with ASD. So the ASD children were in the blue bar, the control children were in the orange bar, and you can see more obesity, more type 2 diabetes, more hypertension, more hyperlipidemia, more liver disease. So children with ASD need thorough evaluations, not only screening for their obesity, but evaluations for comorbidities. Now the question comes up, who should manage obesity in these kids? So in a survey of 327 general pediatricians asked this question, basically who should manage these kids, 62% of the pediatricians said they thought they should take primary responsibility for managing overweight and obesity in children with ASD, but only 5% felt that they had appropriate training to do so. This is a training gap that we're working hard to close. They did report, as you can suspect, that it was a greater challenge to treat obesity in children with autism, and they tended to refer these children to dietitians or developmental behavioral pediatricians for management because they recognized that they were having difficulty. However, when developmental behavioral pediatricians were interviewed, this was a study, they actually reviewed charts of 4,542 children seen by developmental behavioral pediatricians. They found rates of 15% overweight, 14% obesity, 6% had severe obesity. But in these charts, only 7.5% of children had a weight-related code documented at their visits. And of over 3,000 unique codes, only 4% were related to weight. So children with obesity or severe obesity had higher odds of having a weight-related code. And as you might suspect, being on atypical antipsychotics was significantly associated not only with weight, but the odds of having a weight-related code. So the developmental behavioral pediatricians are possibly recognizing obesity, but not coding their diagnosis. So what happens here? We need both of us to be helping with these children. So primary care physicians are encouraged to work with developmental specialists, obviously sharing your expertise. Developmental specialists have autism-related expertise. Primary care providers have knowledge of weight management. It could be shared with the professionals and also in a position to exert influence on IEPs in schools and support for these children. And also primary care, of course, is a hub, a linchpin, a medical home. So the answer really is both are needed here to help these children. So when we think about a primary care approach to children with ASD, these are some general points. It should be highly structured, not surprisingly. Behavioral patterns and habits are more likely to be entrenched in kids with autism, and family stress is likely to be higher. On the other hand, families may be very well organized to meet the multiple demands of these kids, but the stress is definitely higher. What can primary care pediatricians do? Identify weight-related concerns early on, and we'll come back to that in a minute. So act early. You saw that graph. Our youngest kids have obesity already. Many of them have risk factors from early infancy. Act early when you identify an issue. Refer early if you need help with dietitians or exercise specialists. And really, this calls for individualization, really working with the families to find individual solutions that help their children. So what's happening here when nutrition assessment is a primary part of the obesity workup. And so 50 to 90% of children with autism have feeding problems. And this includes selective eating patterns, rituals, food refusals, and a limited food repertoire. And you can all remember if you've asked a child or a parent what the child can eat, you can well remember getting that list of the 20, 20 foods, most of them white, that child eats and won't eat anything else. So certainly there are challenges. The children with ASD have more feeding problems. And there's a relationship here around mealtime behavior and sensory sensitivity and repetitive and restrictive behaviors. And this food selectivity persists in the population beyond early childhood. So we're all used to the picky eater, and we're all used to the child who has food selectivity. We model good behavior. We keep introducing new foods. This usually passes, but in this population, it often persists. So if we look at these atypical eating behaviors, we see over 70% of children with autism have atypical eating behaviors. Some, a quarter of them, have 3 or more atypical eating behaviors. Well, not even 5% of children without ASD have these same behaviors. And what are these behaviors? We all know limited food preferences, hypersensitivity to food textures, eating only one brand of food. I had a family that would, we were trying to change the child from chicken nuggets at the fast food place to homemade chicken nuggets, and the only way, one of the ways the mom was trying was to get the packaging from the fast food place and put her own homemade chicken nuggets in that packaging. The kid was so sensitive to the branding of that food. They'll often pocket food without swallowing. A small proportion of them have pica. The types of food for children with limited food preferences, I've already alluded to grain products and chicken or chicken, usually chicken nuggets. And there certainly may be a small repertoire. It's helpful to find out what this repertoire of food is. Often you can start working with substitutions of lower calorie versions of this food with the child. Unfortunately, children with ASD also have barriers to their physical activity. They engage in less physical activity and have more screen time and sedentary behavior. And of course, screen time is ubiquitous and a real problem for all children now in the era of COVID, but was already a significant problem for the kids before COVID. They often may have motor skill difficulties, so unevenness or delays in achieving motor milestones, low muscle tone, or postural instability, all of which sort of impede their participation in physical activity, and they may have altered endurance, balance, and motor planning. So they're behind the 8 ball a little bit with physical activity, and more so because of their difficulties with social skills and behavioral control. So it's hard for them to participate often. They may face rejection by peers. So instead of the sport or physical activity being a positive peer experience, it may end up being a negative peer experience. And adults may play into this. They may not be able to or willing to make accommodations for the kids and provide the additional supervision or assistance these kids need. So just to be aware that they face both nutritional barriers and some physical activity barriers unique to them. There's some additional risks here for obesity. Food is often used as a reward for behavior. And in many programs in the old days, and I hope not anymore, but in the old days for autism, food was the primary behavioral reinforcer. So it's important to find out if that's still happening. Obviously, we talked about food selectivity, and of course, weight-promoting medications are involved. So with all of that, they have a higher rate of obesity, they have more risk factors. Pediatricians and developmental behavioral specialists find this difficult, but parents of children with ASD and children who had obesity were more concerned about the child's obesity than parents of children without ASD. So parents are concerned about their child's weight status. They may not be articulating that concern to you, but they are concerned. And so providers are encouraged to raise the topic of obesity prevention and treatment with these families. And you can be sort of assured that parents certainly are already worried about the nutritional factors and physical activity factors that affect their kids and are actually more worried than you might suspect about their child's obesity. Now, we talked about weight bias, and weight bias is ubiquitous in our culture. It's very common for all children with obesity, but it's also common in children with ASD, and this is unbelievable because it's a whole other burden these children have to carry. So not only might they be facing peer rejection and negativity around their autism, if they have obesity, they're carrying this extra burden, and they're actually reporting about discussions with their healthcare providers. And this is where family engagement and child engagement and positive affirming behavior is so important on our parts, because these kids are reporting anger, fear, and frustration when their weight is mentioned, and experiencing weight stigma in clinic visits and everyday interactions. And this included lectures and admonitions, sort of lecturing on the part of providers. So when we think about our own behavior with weight bias and stigma, it's well known that we all have imbibed this cultural stigma about obesity, and you can take implicit bias tests. On the Rudd Center has information about this yourself, and identify your own bias and understand how to recognize it and not act on it. Weight concerns sometimes also became a repetitive, restricted interest on the part of several children who reported body image concerns. So it's not that you don't approach children with ASD around their weight, but you approach it like you would anybody, sensitively, without bias, with understanding and compassion, and offering help to the families. Parents want this discussion, and this discussion needs to happen. Some of the other risks here for obesity are inadequate sleep is certainly an obesity risk for everyone, but difficulty falling and staying asleep occurs in up to 1/3 of pre-adolescents in the general population, but over 70% in children with ASD. Inadequate sleep increases the risk for insulin resistance, and sedentary lifestyle, and poor dietary patterns. So sleep is clearly at play here, and can be a consequence, both a causal factor and a consequence of obesity if the child has developed sleep apnea. Causes of delayed sleep onset are similar in both children with ASD and children without. A lack of a bedtime routine, caffeinated beverages before sleep, inability to fall asleep without a parent, mismatch of parental bedtime expectations and age, and of course the desire to continue with video gaming or screen time at bedtime. So these are all common causes and can be tackled. Night waking may be associated with sleep apnea, and just habit night waking, and parasomnia. So these are all causes in the general population of inadequate sleep. But kids with autism may have additional reasons: sensory overresponsiveness, hard to settle down, abnormalities in melatonin metabolism, less time in REM sleep. So they are already at risk for disturbed sleep. There are neurotransmitters in autism implicated in the etiology that may be involved in sleep onset and maintenance. Children with ASD need to be entrained in a bedtime routine. They have to be highly structured often around this. And sleep problems may be associated with some medication use, specifically selected serotonin reuptake inhibitors. Children with ASD are more likely to have surgery for sleep disorder breathing, specifically tonsillectomies. It may be just a responsiveness to the intensity of their sleep problems and sleep fragmentation. Clearly, you know that tonsil adenoidectomy is a temporizing measure, especially in an older kid with obesity. If the obesity is not controlled, often the sleep problems will come back despite the tonsil adenoidectomy. When you include sleep in the review of systems, consider the impact of sleep problems on abdominal pain, ADHD, and anxiety, or wandering. Sleep deprivation does a lot of strange things. Children need a regular bedtime routine and sleep hygiene, turning off electric media, no TVs in the bedroom, and melatonin has been used to help with sleep onset. Clearly, children with ASD have GI issues. They co-occur with obesity. You see lactose intolerance, GERD, functional constipation. There are many hypotheses about why these GI symptoms are more common. But these particular GI symptoms, the evaluation is no different than any other child with GI complaints. But addressing GI issues, as always, may have a twist. And so constipation is common. It's also common in kids with obesity. Less activity, less fiber, and not enough fluid are all things that may entrain constipation and can be worked with. And you may need to consult a GI, gastroenterologist or dietitian for concerns about nutritional adequacy. We've talked about that before, as well as food selectivity. So again, you deal with this more or less like any other child, knowing that there may be more specific problems. Obesity may be a medication side effect due to psychomotor slowing and low energy expenditure. There's a higher, if a child has a seizure disorder, anticonvulsant medications are associated with obesity. Children may have, we already spoke about motor coordination and low muscle tone. And active leisure activities should, especially family-based ones, should be a primary strategy here in terms of just moving the child more, overcoming that low psychomotor slowing, lower energy expenditure, as well as reviewing the medications to see if there are any substitutions possible that are still effective. Anxiety and ADHD are associated with sleep problems, GI problems, learning challenges, highly diagnosed in the population of kids with ASD, and as are anxiety disorders. And anxiety disorders and ADHD can complicate obesity treatment, have to be understood and dealt with in the context of obesity treatment concurrently. It's hard to do obesity treatment if you're not concurrently working also on these issues, as well as depression. By adolescence, almost half of teens are prescribed one or more psychotropic medicines. Some stimulants obviously may decrease appetite, but some alpha adrenergic agents may result in sedation and decreased activity. Selective serotonin reuptake inhibitors may result in weight gain in some children. If you need the medicine for the index disease or condition you're treating, you need the medicine. So there's never a reason to remove a medicine that's effective and working. In that scenario, you just pay close attention to the behavioral lifestyle management of what's going on in the child's sleep, nutrition, and physical activity. You never remove a medicine that's needed. If there's no substitution possible, you can still get weight loss. You just need to really hone in on some of those lifestyle behavioral factors. And here, rapid weight gain, and sometimes your antipsychotic meds cause rapid weight gain. That's more associated with metabolic syndrome, so be aware of that. And then disruptive behavior itself may be related to obesity, probably through the mediator of just tantrums and activation around food, and may be related to the folks using food rewards around that disruptive behavior. So a review of systems should include all the common behavioral symptoms we talked about. Behavioral changes may, obviously in children who can't report specific discomfort due to language impairment or altered sensory reactivity, may just be acting behaviorally, and you have to be careful to really look for underlying causes. You need to understand what medications are being used. Some folks have tried metformin to minimize weight gain. Metformin is not a recommended drug for weight gain. It's a recommended drug for type 2 diabetes. Genetic disorders have been associated with obesity that also have a risk for ASD, and these are Down syndrome, Smith-Magenis syndrome, Prader-Willi syndrome, and deletion of 16p. You see the characteristics there. In any child, especially with early onset obesity, you need to be aware of thinking about genetic disorders as a causal element in their obesity. They usually come, as you see there, with many other constellation of symptoms. So when we think about the expert recommendations specifically, I just want to spend a few minutes going over how you use them in the context of a child with ASD. So we know we need to assess children's height, weight, plot their BMI, classify it, but measuring and weighing children with ASD can be challenging. So you might consider flexibility in the way you measure, such as leaving the shoes on, having them hold a favorite object in order to obtain the best possible weight. I have in the past weighed the shoes and toy and subtracted it if I really wanted to. As long as you're consistent time over time, you can have the parent hold or stand on the scale with the child and then weigh the parent. If they do not want to stand against a stadiometer, you can have this stand against the wall, which is what we do at home. The parent may want to try to obtain the height or weight at home and report in, less accurate, but may be needed. If a child can't stand long enough to obtain a height or is in a wheelchair, you can use arm span or knee height. There are charts for segmental heights. And you can save the vital signs till the end of the visit when the child is possibly a little calmer. The expert recommendations recommend that we should address weight management and lifestyle issues with all patients on a yearly basis, and a staged approach should be taken to children whose BMI is over the 85th percentile for age and gender. In children with ASD, primary care providers should not assume that parents of children are not concerned about their child's weight. We talked about that. They are concerned. So this is something you should address just like you would in a child without ASD. In addition to including the primary caregivers, though, and the family in your discussions around weight, school is a big player here, and other treatment personnel may need to be involved, behavior specialists, and you may need to and want to include eating and physical activity goals in the child's IEP at school. The laboratory workup in a child with ASD is no different than any other child. Glucose, lipids, and liver enzymes, other studies have clinically indicated. Assessing dietary patterns, as we talked about, these are just you assess all the evidence-based factors you see there in any child. The AAP recommends recommendations around diet remain appropriate, but parents may struggle because of all the challenges we talked about. So children with ASD are frequently food selective, as we know, and some simple screening questions around food selectivity can be, does your child eat from all food groups on a daily basis? Parents may start laughing when you ask that. Is your child specific about brands of food or food presentations? What are the favorite foods? Patterns of concern here are very low or no consumption of entire food groups. Problem here, high consumption of sugar-sweetened beverages or high-fat sugary items, and sneaking or binging or vomiting from overeating are flags that you need to be concerned with and hone in on. Strategies you can use to promote healthy eating at home. Sometimes children respond really well to being involved in shopping, planning, and cooking, if this is of interest to the child. Plan meals to introduce new foods, at least one food that the child likes, though, in every meal. So put one thing down that the child will eat. Offer healthy snacks in portioned out amounts, not the bag, but on a plate. Act as role models. Offer water. Some of these you're familiar with all kids. Use positive language. Don't have the parents browbeating the children about eating habits, and increase structure around meal times. Again, you may want to have the parent display a schedule for meals and snack times, so the child knows in advance when is that meal coming, when is that snack coming. Remove distractions during eating. Offer some choices of some healthy options so the child has some control over what they eat. They may need to examine the new food before they eventually taste it. So they may need to see it, smell it, touch it, have it on their plate for multiple meals before they eventually taste it. Don't give up. And consider modifying the texture. If you can, if they want it ground up, chopped up, whatever they need texture-wise to have it be more acceptable. And then, of course, avoid using food as a reward. In school, preschool, childcare, or school, the child, make sure that the parents know what the child's actually eating. Sometimes kids have breakfast at home and breakfast at school, and unknown to the parent. Ask what's happening at school. Use physical activity as a reward if the school can do that. Review the menus. Try pre-ordering the school meals if you can. Sometimes parents have to actually pack healthy food and include healthy eating goals in the IEP. And with in-home support staff, you're asking staff to model healthy behaviors, include healthy eating, physical activity goals, and treatment plans. Ask the staff to not flash their soda around or their snacks, and find alternatives to using food as a reward. And then include eating goals in individual treatment plans. Physical activity, consider ways the whole family can be active. This works very well. And then involve the child, if you can, in home-based activities, helping with the chores if acceptable. All this, of course, has to be individually tailored to the child. With respect to school, federal law requires children receiving special ed to receive physical education, so that should be happening. Explore ways to increase physical activity at school, movement breaks if you can. Include the phys ed teacher if you can on the IEP team, and this is all in hope that we'll all be back at school, of course. Consider using community-based activities to provide physical education. Request and adaptive physical education services if the child cannot participate in general PE. Can they have a semi-structured recess? And be sure, please, that the school is not taking recess away as a punishment. That shouldn't be happening with any child. So physical activity, schools can be a great venue for physical activity, and without schools, we know that many children are gaining weight because they don't have the eating and activity supports that they would at school. For the in-home support staff, again, trying to be active role models, including physical activity goals and treatment plans, is very important here. We all want to know this. I think I've switched from limiting screen time to, can you please walk around for 5 minutes every hour you use a screen, because this is almost impossible at this stage with COVID. But if you can keep the screens out of the kids' bedroom, if you can take those short movement breaks in between screen time, maybe schedule the movement breaks, this can be helpful, and use the outside as a break time from screens. Again, school can be helpful here, and in-home staff can also be helpful in promoting physical activity. When we move into Prevention Plus, where things are getting more structured, there's more goal setting, there's more monthly follow-up. You see we reviewed the evidence-based targets you have here, and involving parents here is essential. And so gradual reduction, your goals, if the child's drinking a lot of sugared beverages, might not be total elimination. Might be, can we stop drinking juice with lunch and drink water? Can we dilute the juice? Can we put a 1/4 cup of water in with that and 3/4 cup of juice? It might have to happen that slowly. So you want to have the target in front of you, but you're gonna have to make really slow, incremental change here. Maybe you want to keep foods that the child's not locked onto outside. Don't bring them into the home so that additional temptations are not there. Make sure you serve something that the child likes at every meal so meal times don't become hysterical. And then small incremental goals, a few small goals achieved are much better than a long list of goals that nobody can accomplish. In structured weight management, again, we're involving other healthcare providers now. It's become a little more difficult for the child and family. And here you see a lot more supervision, structured meals, supervised active play, control, if you can, of screen time, monitoring target behavior. So this is getting more highly structured. All of stage 1 and stage 2 recommendations are appropriate for children with ASD, but you may want to entrain services of a professional, OT, speech therapist, behavior specialist, dietitian. Posting a meal or snack schedule. Make it in pictures if you need to. Using pre-prepared, pre-portioned out snacks. Implementing a reward chart for completing a physical activity, trying a new fruit or vegetable, or drinking water. So you can see how the structure is increasing and the support needs to increase here. When we get to comprehensive multidisciplinary intervention, this is usually a weight management program. Again, you can see the multidisciplinary team is coming in. Stage 3 is the same for all children, but may want to include longer weekly visits while you're trying to get hold of things, using food lists and guides, removing trigger foods, planning for a favorite food to be consumed in a planned way to prevent deprivation, but not as a reward. Consider having family track calorie intake, and identifying locations for physical activity. So you may need, even if the child's attending a weight management program, these are the kind of strategies that may need to be added in. By the time you get to tertiary care, this is where all of the things you've done before are in play, but we may use meal replacements, low-calorie diets, medication, possibly surgery. And in children with ASD, certainly they should not be inhibited from availing themselves of the most intense possible treatment needed. Again, families have to be involved in tracking calories. There may be medication use here. And surgery, the guidance from the American Society for Metabolic and Bariatric Surgery indicates that ASD should not be a contraindication for bariatric surgery. They have to be reviewed like any other patient. There are very formal and well thought out guidelines that the Academy has put out about how to evaluate any child that's approaching metabolic bariatric surgery, obviously considering it case by case. But the bottom line here is children with ASD should be availed of all the possible obesity treatments as any other child. It just has to be tailored for them. These are some resources you could use. The website at the Institute for Healthy Childhood Weight. We have lots of resources about nutrition, physical activity, and obesity. Let's Go has a toolkit for children with intellectual and development disabilities. And there's a kit there, Fostering Positive Weight-Related Conversations. So I hope you've gotten some tips out of this talk. And I would like to thank you very much, and I enjoyed being with you today.
Thank you so much, Dr. Hasnick. Anybody have any questions or other things they'd like to discuss?
If you have your hand raised, please feel free to unmute and ask your question.
Two questions. One, you mentioned the app that would help. Could you please tell us what that was? And then when you were talking about medication use in stage 3, what medication were you speaking about?
So the app is called Change Talk. Change Talk. If you just look on your app store, it's right there. Medications, there's now 2 approved medications only for children, Orlistat and I'm blanking on the other name, it just got approved. So there are not many medications here for children. And I alluded to metformin, but it's not officially recommended for weight loss. So at this point, what you're mostly dealing with in a child who has medications that cause weight, or trying to make sure you're working with a subspecialist to see if there's any possible substitutions and working around the lifestyle behavior. I think at this point with weight management medications, if you're going to be thinking about that, it would be wise to get hold of your endocrinologist or your weight management specialist to help you think through what you might do, because the choices are pretty limited here, and not actually, orlistat, for example, is not very well tolerated by kids because of the GI side effects, which would be a problem for some of the kids with ASD.
I really like the idea of involving the school physical activity into the IEP. I don't know that I've ever considered that, so definitely something I think would potentially be a big help for kids as they get back in school, for sure. Thank you.
Yeah, well, we know and we fear that weight gain, obesity rates are going to rise and are rising from the little bit of data we have during this pandemic. So I think we're all going to have to be looking at, thank you, liraglutide, Paul, is the other medicine just approved. Thank you very much. We all are going to have to really be focused on how we can maximize the nutritional and physical activity benefits at school here when they get back. There was a question about off-label use of metformin. I can't comment on that. I don't. I know it is being used. I don't know of any studies that have evaluated it. So I would, at this point, consider it an off-label use. It's only really approved for children with diabetes at this point.
Hey, this is Chris Peters. Just to follow up the metformin conversation. I think there are 2 small studies in children who are already on atypical antipsychotics, and metformin was added. And it seemed to, for the majority, seemed to put a sort of a lid on weight gain, not necessarily leading to weight loss in all the participants, but you could sometimes stop the rapid weight gain for some. So you will see that as an attempt to allow people to stay on an atypical when it's working well and maybe other things haven't worked. You'll sometimes see that metformin tried in that way.
Yeah, I really appreciate your comment. And just 2 things. If you do use it, know that it does have a limit. It doesn't. And you have to keep them on it for it to work, obviously. If you know a kid is going to go on an atypical, it's also worth reviewing some lifestyle changes prior to them getting on the atypical, especially what's in the environment of the home, to see if you can get a handle on it proactively. But I do appreciate your comment. People are really the atypical antipsychotics with that rapid weight gain. As we said, it is a trigger for metabolic syndrome, and I think that's been the genesis of where people have wanted to use metformin to get a grip on that.
Yes, and thank you for a wonderful review of this topic.
You're welcome, and thank you for your comments.
Well, Dr. Hasek, that was just great information. I really appreciate you being with us today. It was an honor to have you as our speaker today, for sure.
Well, it's my pleasure, and everybody take care and stay well. Thank you very much.
You too. Thank you very much.